So we're going to start off by comparing the neonatal or neonates upper airway from that of the adults. Usually you do some comparison after the baby is born. Okay? That's, in other words, you're doing some more assessment, but this will be afterwards. Okay? All right. Infants' upper airway. Their tongue is usually proportionately larger than that of this adult compared to their body size. They have big tongue than we do. Infants have large amount of lymphoid tissues in their upper airway compared to the adults. Their epiglottis is proportionally larger. Okay, it is larger than that of the adult because in the adult ours is kind of like pointed, elongated and pointed like that. But for the baby, it's always like more horizontal like that, or what they call that omega shaped. That enables the baby to be intubated very easily. Babies are very easy to intubate. Sometimes you don't even have to lift on anything to see their glottis. It's almost like it's always there. Okay. Their epiglottis is very flexible compared to ours, and it lies horizontally. The narrowest portion of the neonatal airway, upper airway, is the cricoid cartilage, at the point of the cricoid cartilage. For the adult, is the glottis is the narrowest portion of the adult's airway. For the baby, is the cricoid cartilage. Okay. Infants are at a greater risk of airway obstruction. Okay. One of the most common things that will cause airway obstruction in a baby is secretions. Okay. Secretions tend to block their airways more than anything else. But they can also have swelling in their upper airway, okay, especially when they have any kind of viral infection. And that swelling may result in respiratory distress. And then the baby will exhibit retractions. Okay, retractions are like the baby is trying to overcome airway resistance to breathe. So what happens is you have their skin sinking in when they breathe. They go like that. So their skin will sink in. So if their skin is sinking in, if you can see it on top of the breastbone, that is called sternal retractions. Sternal retractions. Here, you want to sink it in, okay? Or maybe they can have it on top of the breastbone, right here. You see the skin sinking in, and that is called supra sternal retractions. And then they can have it between their ribs. Okay? And that is called the intercostal retractions. So all they are doing is trying to overcome airway resistance to breathe. So it is a sign of respiratory distress in a baby. Another sign of respiratory distress is grunting. Grunting. Grunting is when the baby begins to exhale against a partially closed glottis. The airway is kind of closed a little bit, and then they're trying to exhale through it. So what they're doing actually is trying to create PEEP in their airway. Like that. They'll be very hypoxemic to do that. So they're trying to create PEEP, artificial PEEP, in their airway so that they can increase their oxygenation. So it's a sign of respiratory distress. And then they can also do a nasal flaring. So you watch them breathe, they widen their nostrils like that to try to get more flow into their lungs. So this here, anytime you are told that a baby has retractions or grunting, immediately you're going to start thinking about CPAP. What's that?
No, yeah.
CPAP is what we're going to initially put them on, okay? In most cases, even before you try to intubate the baby, they're having a problem, usually we'll try them with CPAP, okay? If things are not getting better after they have reached like a FiO2 of 60, then that's the time you intubate them, okay? Any questions about signs of respiratory distress?
Can you go over, so the above the breastbone you said is suprasternal?
Suprasternal retractions?
Is above the breastbone instead of?
Yeah, right there where you have your hand, yeah.
And then the sternal retractions?
Sternal is right here, on the breastbone.
Breastbone.
Yeah.
Thank you.
So their chest, infant's chest has little stability because ribs and sternum are mostly cartilage. Okay? Their ribs have not actually formed well into bones. So they're a little unstable. Adequate ventilation requires the use of diaphragm, like us. Okay, if you want to draw in more tidal volume to increase ventilation, well, you're going to have to take deeper breaths. That means you're going to have to drop your diaphragm way low so that you can create enough negative pressure. The amount of negative pressure that you create when you breathe in is what determines the amount of tidal volume that is going to come in. That's not always the case with babies, okay? Babies, to increase their ventilation, they do that by breathing faster, okay? They will mainly do it by breathing faster instead of trying to generate huge tidal volume, okay? Low pulmonary reserve factors. The heart is large in proportion to the thoracic diameter. So they have large heart compared to their body size. Their thoracic cage offers little stability. Proportionally, large abdominal contents push up against the diaphragm for the babies. Their diaphragm is kind of like pushed up. Now, when your diaphragm is pushed up, it makes it a little difficult to breathe. When your diaphragm is flat, it makes it a little difficult to breathe. So either way, you are dead. So like in a COPD patient with flat diaphragm, they have difficult time to breathe, okay? And then if you're obese, for instance, you're obese, you're very big, all that weight is on the diaphragm too. You can't breathe, okay? All right. So now, when we start talking about some of the congenital abnormalities that you can see with babies, there's something called the diaphragmatic hernia. Okay, so diaphragmatic hernia is where the baby is born and all the baby's intestine will move up to their chest. They will have very flat stomach, which is called the scaphoid stomach. You can barely hear breath sounds because all the intestines are inside the chest. Babies tend to breathe in through their nose as opposed to breathing in through their mouth. So their nose is the primary respiratory organ. Because for us, if your nose is blocked, you can do it through your mouth. It's not always the case with the baby, so we have to make sure that nothing is blocking their nose. Okay? Keep it suctioned out. Okay? They have congestion in their nose, they can't breathe well. If you've seen a baby that has cold, or some kind of viral infection that is causing their nose to run, you're going to find out that they don't breathe well because something is blocking their nose. Metabolism. Metabolic rate is higher in infants compared to that of the adults. As a result of that, they have greater oxygen need. Because metabolism requires oxygen. The faster that you are metabolizing, the faster your body will demand the oxygen. So, due to varying metabolic rates, infants can have different responses to medications. The drugs need to be metabolized. Okay? They need to be deactivated, and the liver does that. Okay, so gestational age assessment after birth. These two here are probably the most important in this lecture because you gotta recognize them. Okay? Now, there's something called the Dubwitz gestational age assessment. Once the baby is born, they will look at 11 physical signs and 10 neurological signs that the baby has. Okay? And just like in the APGAR assessment, each area in the physical or the neurological sign is assigned 1 to 5 points. Okay? 1 to 5 points. You look at their color, you look at different things, you assign a score of 1 to 5 to each one of them. Then after that, you add your points together. Okay? Now, if all the points add up to 40, then that would mean that the baby is term, that the baby is 40 weeks. Okay? That's all you really need to know about this. All the points add up to 40, the baby is 40 weeks. If all the points add up to above 40, let's say 50, well, it doesn't mean that the baby is 50 weeks old. I can't imagine any mother carrying a baby for 50 weeks. So the way you're going to read that is that the baby is post-term, okay? And then if all the points add up to below 40, the way you're going to read that is that the baby is preterm, okay? And then there's another one that is called the Ballot Gestational Age Assessment, pretty much like the Dubwitz. It's just that in this one here, you're looking at 6 physical signs and 6 neurological signs, okay? Because you're not looking at so many signs, it is quicker. It is quicker than Dubwitz and it's better. Right? Okay. So just remember that the Dubwitz and Ballot gestational age assessment after birth. Okay, after birth. to determine whether the baby reached term. All right, so these are some of the signs that they look at, for the ballot. Okay. Vernix. The vernix is like that milky stuff that is on the baby's body after the baby's born. That milky stuff. It's almost like white in color. Okay, that's called the vernix. And the vernix appears 20 to 24 weeks. Okay? Thickest at 36 weeks and disappears at 41 to 42 weeks. So if the baby is born with it, then you know what that means. That baby is probably not term baby. Okay? They have a lot of vernix on their body, on their skin. They probably did not reach term because it's supposed to disappear really. And sometimes they come out with a little bit of it. All right, so at 25 to 26 weeks, if you look at their skin is very gelatinous and transparent. In fact, you can see their blood vessels. Okay, if they're born very prematurely, you can see their blood vessels. Okay, so when we see that, then that's a sign that the baby did not reach term. Okay, if you can see their blood vessels through their skin. And then there is lanugo. Lanugo is baby's hair. Sometimes they have a lot of it back here. Those fine, pretty hair, okay, on their skin. Lanugo. It appears around week 26 and begins to disappear at 32 weeks. So that means that a baby that is premature will have a lot of baby's hair. And then the ear matures with increasing gestational age. It looks more like that of an adult at 34 weeks. Okay, it looks more like us at 34 weeks. And then if you look at the breast area, initially the way the breast forms is that you're going to have a circular, kind of like reddish area there. Circular and reddish in color. That is called the areola. Areola is that reddish circular patch there. Usually that will appear at week 27. And then at week 30, then you will actually have the breast bud developing. Genitalia. Now, rugae, that would be in a boy. Rugae is like the wrinkles that you see on a mature scrotum. The wrinkle on a mature scrotum is called the rugae. Okay, so the rugae appear, and the texts will begin to descend in week 30 to 32. Okay? And for the females, the labia minora is the skin fold that covers the clitoris. Okay? And then when they're pretty young, it's almost like their clitoris is very visible. Okay? But as they grow older, the skin fold will grow and try to cover it up. So that would be around 30 to 32 weeks. And then zoochrysis. Zoochrysis is like the wrinkles at the bottom of on your sole. Those wrinkles on your sole is zoochrysis. It is more with increase in gestational age. So if a baby is born and they don't have those zoochrysis, then they're younger. Okay? So these are the signs that they look at the ballot. Any questions about that?